Good afternoon. My name's Dr. Diana Kirke. I'm a head and neck surgeon, laryngologist, assistant professor at the ICANN School of Medicine at Mount Sinai. And this afternoon, I'll be talking to you about all things thyroid. The thyroid gland is a hormone-producing endocrine gland, and it really is the center of our metabolism. Without it, our cardiovascular system wouldn't be able to function properly. Many of our basal metabolic functions or a basal metabolic rate wouldn't be able to function properly. So it's really the centerpiece of our body. It's incredibly important. The thyroid gland is located within the center of our neck. It sits on top of our windpipe, and generally itself, the thyroid gland is not palpable. So when you feel an abnormality in the center of the neck, such as an enlargement or a swelling, it's likely that it's coming from the thyroid gland itself or an enlargement within the thyroid gland itself. The commonest symptom of thyroid gland pathology is a nodular enlargement rather. That would be the most common symptom that one would feel. The other common symptoms are a change in voice, hoarseness, or trouble swallowing when these nodules become incredibly large. Thyroid cancer very early thyroid cancer doesn't always necessarily manifest with any symptoms. As the thyroid cancer grows, though, it becomes more of a palpable nodule, and that's when symptoms become more obvious as the thyroid cancer continues to grow. Once again, as the thyroid cancer becomes bigger, then you would also get some abnormalities within the voice as it invades surrounding structures, such as the nerve that goes to the voice box. And it can also impact on the swallowing or the food pipe as the nodules or the mass gets bigger. All of these things I would assess you for as a dual fellowship trained laryngologist and head and neck surgeon. Part of the journey depends on what the patient feels. If there's any concern about a family history of thyroid cancer, then your primary care doctor would generally arrange an ultrasound as a screening tool to examine the thyroid. And based on that, you may end up seeing me in the office. If there's any palpable nodule that a patient would feel, then similarly, they would also get a thyroid ultrasound and some blood work with their primary care doctor, and then they would be subsequently referred on to me. Prior to that referral or around the same time as that referral, even as a result of seeing me in the office, you would then likely get a fine needle aspirate of the thyroid nodule if it met certain criteria, and that would give us further information as to what exactly is causing the symptoms that the patient or the primary care doctor had discovered. That's a great question, actually. The thyroid cancer is more predominantly within females. The rate is quoted to be somewhat in the order of 3 to 4 times more common in females than in males, and that's for several reasons, we believe. One of which is patient selection. Females are more invested in their health usually, and will get more commonly screening tools to examine their thyroid than males. There's also very likely some other hormonal issues at play, which we don't understand as well as the tendency to get more investigations for the thyroid gland. But absolutely more common in females than it is males. Thyroid cancer is undoubtedly a surgical disease, and generally the surgery entails either removal of half the thyroid, which is a hemi-thyroidectomy, or removal of the total thyroid, which is the total thyroidectomy. In further instances where there's spread outside of the thyroid gland, there may be a central neck dissection or even a lateral neck dissection. So the treatment for thyroid cancer is still undoubtedly surgery. That is a wonderful question. If you were to ask me that question 10 years ago, I would have said absolutely not. But the paradigm is certainly starting to shift, especially for disease that is caught exceptionally early. and is probably less than 1 centimeter, there is an option to surveil the thyroid gland very closely at 6-month intervals. However, that is a discussion between the patient and the physician, surgeon like myself, that requires very close follow-up and very close monitoring. And it has to really depend on the patient too, whether the patient themselves feels comfortable with that. So if I have a very highly reliable patient that's willing to do that, then absolutely it is an option. Also, another wonderful question. And once again, if you'd asked me this about 10 years ago, I would have said absolutely not. There is no role for a hemi-thyroidectomy. It's only total thyroidectomy. But once again, the paradigm has significantly shifted in the last 5 years. If the disease is quite localized to one side of the gland and it's less than, say, 4 centimeters, then absolutely a hemi-thyroidectomy for papillary thyroid cancer, a well-differentiated thyroid cancer, is absolutely an option. The benefit of that is that the surgical time is obviously less. The risks of injury to the nerves and to the surrounding parathyroid glands are obviously less. The patient recovers a lot quicker. It's ambulatory surgery. And most importantly, they still have half a thyroid gland in place to produce thyroid hormone, endogenous thyroid hormone, meaning that they don't have to take thyroid hormone replacement or rely on a pill to take thyroid hormone replacement. If there's any concern for spread of tumor across the midline of the thyroid gland is divided into 2 halves. If there's any spread of the tumor across the midline, or they have multifocal disease throughout one side, or if it's larger than 4 centimeters, then total thyroidectomy is really the best option. The surgery for that is a little bit longer. We still try and do that in an ambulatory fashion. The risks of the surgery are slightly different, and you do need to take exogenous thyroid hormone, such as levothyroxine, for the rest of your life, but it's necessary to maintain your basal metabolic rate. You certainly need a total thyroidectomy if your disease dictates that, but it is honestly the best treatment if your disease does dictate that in terms of potential recurrence down the line. It would lessen your chance of recurrent disease. So all these things are taken into consideration at the time of the initial diagnosis. It's a considered decision-making process with the patient and the surgeon. So for obviously different depending on whether it's a hemi or total thyroidectomy. Hemi-thyroidectomy is in the rough schema of an hour and a half, inclusive of anesthetic time. A total thyroidectomy is in the rough territory of an hour and a half to 2 hours. Both surgeries, there's a possibility of ambulatory nature. It's more so with a hemi-thyroidectomy. Obviously, that also depends on the bulk of disease. If there is a lot of thyroid cancer disease within the thyroid and with outside of the thyroid, those surgery times lengthen, and then there's a potential that you would possibly stay in hospital. But certainly the recovery from thyroid surgery is about a week. I advocate for patients to take 1 week off work just to recuperate and recover. I certainly tell all my patients to avoid heavy lifting for about a month rather, in order to enable good healing or good cosmesis of the neck incision. Usually you can talk straight after surgery. The reason for that is in a number of regards, actually. Number one, we monitor the nerves that go to the voice box throughout the surgery. We identify those nerves. So there's always a consideration of the recurrent laryngeal nerve, or the nerve that supplies our vocal cords and is responsible for our voice. There will be some sore throat and hoarseness potentially from the tube because it is a general anesthetic. You can't really do the surgery without a general anesthetic. So you will have a sore throat and possibly some discomfort from having that general anesthetic tube. So generally about a week, but you can talk straight after surgery. And generally I recommend a soft to a full diet. Once again, purely related to the tube that helps you breathe throughout the surgery. But we are very careful with the nerve that goes to the voice box. So the surgery is safe in professional voice users as well. It's very unlikely with thyroid cancer to progress to chemotherapy and radiation therapy in the traditional sense. For advanced thyroid cancer, generally what we would progress to after surgery is not chemoradiotherapy, but rather radioactive iodine, which is administered in the form of a pill. That's given in an ambulatory fashion. And what that radioactive iodine does is it will ablate or act on any residual microscopic thyroid cells in the body that obviously we can't see with the naked eye, and will remove the risk of any potential microscopic thyroid cancer remaining behind after the surgery. And that's generally it. It's really only in the recurrent setting of thyroid cancer, or when the thyroid cancer presents in a very advanced manner, which is not what we see generally, that radioactive iodine, radiation, my apologies, would be used. In that setting, it's not a well-differentiated thyroid cancer anymore. It's a de-differentiated or poorly differentiated thyroid cancer. That's where we would use radiation therapy. We're also looking at the use of immunotherapy now with the genetic testing that we're doing on thyroid cancers. So that also may start to play more of a role in the coming months to years. So generally, as I said earlier, it's a surgical disease. It's incredibly low, actually. Obviously, we would monitor the residual thyroid tissue with a 6 to 12 monthly ultrasound. We would also do regular blood tests to biochemically track the function of the gland. But the actual quoted rate is anywhere between 4 to 9%. So it's quite low. So that's why we have shifted our thinking from going to traditionally a total thyroidectomy, which is where I was back in 2006 when I entered into my training, to now very much doing more conservative surgery, which is more a hemi-thyroidectomy. So in the appropriate patient, it absolutely is a very safe and valid surgical option. The two biggest risks for thyroid malignancy are genetics, which we'll see more of an emergence in genetic counselling and genetic mapping in the next months to years. We're starting to understand that a little bit further, and we're also doing a study ourselves on that here at Mount Sinai. The other great risk is radiation therapy. So anyone that's had prior radiation treatment or been exposed to radiation through external means needs to have regular monitoring of their thyroid gland. So they're the two biggest risks. In terms of dietary supplementation with iodine, that's generally something that we don't have to do in the United States because we have very iodine rich foods. It's only something that you would need to consider if you were a vegan and you're not getting those extra supplements of iodine in your regular daily diet, amongst other nutrients. So it's not something that we generally need to do in the United States and first world countries. So outside of that, it's really just having a healthy diet full of fruits and vegetables, and approaching life in moderation, which I think is really the best thing to ward off most diseases in our lives.